Hello, my name is Ji Huang, and I am the United States nurse practitioner today. And I'm gonna do the abdominal exam for my coworker here today. And let me zoom out around the room to make sure there's no people first. Let me turn it. Okay, so here is the ceiling, and then let me turn around. My patient is here, and then there's no people, no assistant, no, nothing on the wall too. And first, I have to ask my patient, are you able, can I have your name? My dear, are you able to, no, wait, do you give me the consent to videotape you and put it on YouTube for my abdominal exam for my class?
Yes.
Okay, he give me the consent, and I will do the hand sanitizing before I go into and examine the patient. First, I will ask, do you have any concern about your abdominal today?
No.
Okay, can you help me lying down first? Okay, so my patient is lying down, and I will put a pillow underneath for him, so the abdomen will have more distension, and the patient will get more comfortable while we're doing the exam. And I put on a dress for him to cover his foot right here for his privacy. Okay, so first I will do the inspection. I will can you lift up your shirt up to your nipple line? Okay, and then I will do the inspection for his abdominal. First, I noticed there is no bruising, no peristalsis, no ascites, and also no dry air. It's really brown contouring. The abdominal appear healthy to me. The first one I will do is like after ups. So the next one I will do is listening to the bowel sound. I will start to listening the bowel sound from the right lower abdominal, and to the right upper abdominal, and then to the left upper quadrant, and then to the left lower quadrant. So so the bowel sound should be from 5 to 30 sound bowel sound every minute. And if it's less than 5 bowel sound, it will be hypoactive. And in order to diagnose a patient to be hypoactive bowel sound, you have to listen the bowel sound for more than 5 minutes. And while I'm listening to the bowel sound, I can listening to the aortic abdominal. No, I will listening to the liver and to the spleen first, to make sure there is no liver, there's no hepatic growth or any spleen growth. So I'm listening to the liver side with my stethoscope and my diaphragm. I'm listening to the spleen with my diaphragm and my belt, and make sure there's no buoys, there's no friction drop on the hepatic and the spleen side. Next one, I will move on to the aortic abdominal. So listening to the aortic abdominal with my bell and diaphragm, and listening to the renal artery with the bell and the diaphragm, renal artery with the bell and the diaphragm, and iliac artery with the bell and diaphragm, and listening to the iliac artery with the bell and diaphragm. Usually if the patient, I have to remove the bell and listening to the femoral artery right here with the diaphragm and the bell due to the video. That's why I do not remove the patient the pants right now. So I'm listening to the bell to the femoral artery with the bell and the diaphragm of the stethoscope, and moving to the left side with the iliac artery with the bell and the diaphragm too. Okay, and then next one I'm gonna do the percussion. Most of the time, the abdominal sound will be tympanic because like the abdominal have to be filled with air. If the patient have any fluid there, you will hear the those sound, and you can hear the those sound in the liver and the spleen side too. So I'm gonna palpate with my abdominal hand, and then I'm gonna do a quick palpate on the distal finger, on the distal middle finger. So I'm gonna do it fast, like two tap and then release them. You have to hear the tympanic sound of during on the form quadrant, and then and then we can start from the mid clavicle on the right lower quadrant. You can percuss up until you can hear the dullness. That's when that's when you meet the patient liver margin right here, and move up to the intercostal space. Make sure you percuss on the intercostal space. You don't want to percuss on the grip, and then because like if you percuss on the grip, it will be a dull sound. So just move up like to intercostal space, and then try to percuss the sound right here, and you expect to hear a dull sound. That's when your liver is, and for a normal healthy person, the liver should be 7 to 10 centimeter. If the liver is bigger than 2 centimeter, the patient will have enlarged liver. And then you can move to the left upper quadrant to percuss on the spleen. We will do the same thing. Sorry, the spleen, you have to check on the lower the grip right here, and move up to the 10th grip. That's when you can percuss the spleen, and you're supposed to hear the dull sound on that area. While you moving next to percussion, we can percuss the bladder too. If a patient have 400 to 600 millimeter urine up on the bladder, you will expect to hear the dull sound on that area. That's why before we check the abdominal area, we only ask the patient to empty the bladder. That area, the bladder should be heard with the tympanic sound. And moving on to palpation. We start with the light palpation first, just 1 centimeter. So we just want the patient to be familiar with our hand and our hand finger and our touch. And we can notify the patient face if there's any tenderness. We can palpate any surface masses. So basically, I will do just a slight palpation on 4 quadrant, and we can check on the patient's face. So there is no grimace or no tenderness on the patient's face right now. So basically, there's no masses on the surface right now. And while we doing the palpation, we can palpate on the right upper quadrant. So right here is the costal margin of the grip. So we can I'm so sorry. After the slide palpation, we're moving to the heart palpation. So for the heart palpation, we can do deep to 3 to 5 centimeter, and we will do the same thing on the right lower quadrant, and then go to the right upper quadrant, and we gonna moving to left upper quadrant and going down to left lower quadrant. While we palpate on the heart on the abdominal, on the right upper quadrant. So we're gonna check on we're gonna percuss again. So until we can find the liver margins. So the liver margin will be heard with a dull sound right here. So we can mark a mark right here to check on the liver. That's when we can palpate hard, put the finger down, and then up to the rib costal area right here. That's when we can touch the patient liver with our fingertip right here. Okay, and I'm so sorry again. So if the patient, if we usually we can palpate the patient liver. If the liver is more than 7 to 10 centimeter, that's when the patient have enlarged liver. We cannot palpate the patient liver with the slide palpation. And moving next to the left upper quadrant, usually we cannot palpate the patient's spleen. That will be normal, a healthy patient. If we are able to palpate a patient's spleen, that means patient have spleen enlarged spleen. And moving next to we can go back again to the right upper quadrant. When we push down on the right upper quadrant right here, and the patient complain of tenderness, when we pushing down, when he inhale, that means he suspected he may have a cholecystitis, basically a gallbladder infection. And so moving on to the right lower quadrant, right here is the hip bone, and right here is the umbilical. Two-thirds of the between of the umbilical and the hip bone. If we do a deep palpation right here, when the patient is inspiration, and when the patient complain of tenderness right here, that means the patient suspected quick appendicitis. This technique is like we palpate with the Marconi board, and if the patient is suspected with appendicitis, he will complain of pain. The other way we can check the appendicitis is to palpate hard on the left quadrant, and then when the patient complain of pain on this side, that means the patient have appendicitis. And another way to check if the patient have appendicitis is to ask the patient, can you bend your knee on this one? Okay, so when the patient bend your knee, and then can you move the foot, can you rotate the foot, the knees? So when the patient rotate the knee and then complain the pain on this side, that means the patient may have appendicitis. Oh no, I'm so sorry. The patient may have yes, a patient may have appendicitis, peritonitis, and okay. And then the next one, we can check on the patient. If there's another nurse right here, we can ask the nurse to put the hand right here, so we can keep on the organ in place. However, there's no nurses right here. We can ask the patient to help. Just put your hands right here, so we can divide the abdominal to two parts, and then keep the organ in place. I can use two of my hand on this side, and then when I palpate this side, I mean like the fluid. If the patient have ascites, the fluid will move from this to this side. That's why I will put my finger down here on the right lower quadrant. When I press hard on the right upper quadrant, no, I'm so sorry, on the left lower quadrant, if the patient have any ascites, the fluid will move on this side, and then it will touch onto my hands on right here. And then another technique, we can ask the patient to turn to your right side. Can you turn to your right side? This one, yes, this one, yes. So we can always do the palpate. We can always do the percussion right here to make sure the patient have any ascites. So usually with air we can hear the tympanic sound. With fluid we can hear the dorsal. We can do the percussion right here. If there's a dorsal right here, if patient have ascites, the area right here should be should be heard with tympanic sound, and this area should be heard with a dorsal, and that's when the patient have ascites. And for now, my patient appear to be healthy, and there's no concern about the abdominal. Thank you.